Welcome to this clinical explainer. We are bypassing all the fluff today and jumping straight into an integrative mixed block simulation on nephrolithiasis. We're keeping the tone strictly peer-to-peer, focusing heavily on the intricate mechanisms, the absolute pharmacologic mandates, and the precise radiographic signatures you need to instantly recognize to master these presentations and hit that 280+ level. Let's get to work.
Okay, let's dive right into this. Calcium oxalate stones account for the vast majority of nephrolithiasis presentations. Notice that classic envelope, or maybe a dumbbell microscopic signature. This is your absolute hallmark for calcium oxalate. Now, it's absolutely crucial to recognize that these typically form in normal calcemic patients. The driving mechanism here is hypercalciuria, not hypercalcemia. And because of their dense calcium composition, these are strictly radio-opaque. They're going to illuminate brilliantly on a standard KUB X-ray.
And this brings us to a classic dietary trap. Because we're dealing with calcium stones, a patient's, and honestly sometimes a clinician's first instinct is to just cut out dairy and restrict dietary calcium. Listen, that is a massive error. You absolutely must maintain normal dietary calcium. Why? Well, because calcium binds to oxalate in the gut. If you violently restrict it, free oxalate absorption spikes dramatically, flooding the kidneys and paradoxically worsening the exact stones you're trying to prevent.
So, alongside aggressive hydration, what's your definitive pharmacologic move for recurrent formers? It's strictly adding a thiazide diuretic. Thiazides increase calcium reabsorption in the distal convoluted tubule, literally pulling calcium out of the urine and right back into the blood. No hypercalciuric environment means no precipitation. It's a simple, elegant fix, and it needs to be your immediate clinical reflex.
Now, contrast that envelope shape with this coffin lid morphology. There's no way you miss this one. It's the absolute signature of a struvite stone, which is composed of magnesium ammonium phosphate. This pathology is driven entirely by urease-producing bacteria, classically Proteus or Klebsiella, which cleave urea to form ammonia. This rapidly alkalizes the urine to a pH above 8.0, allowing these massive, highly radio-opaque staghorn calculi to precipitate and just completely fill the renal pelvis.
Module 2, the radiolucent matrix. We've covered the radio-opaque pathologies. Now, we're transitioning into the second module to focus on the intricate mechanisms of acidic precipitation.
Notice the distinct rhomboid, or sometimes rosette, signature here. These are uric acid stones, essentially the radiographic phantoms of nephrolithiasis. Unlike calcium or struvite, they are strictly radiolucent. If you order a standard KUB X-ray, these stones are completely invisible. You absolutely must utilize a non-contrast CT scan or a renal ultrasound if you want to detect them.
Let's exhaustively map out exactly how these phantoms form. The absolute required environment for a uric acid stone is highly acidic urine, requiring a pH below 5.5. Now, while gout and massive cell turnover from something like leukemia are classic triggers, the real high-yield systemic trigger here is chronic diarrhea. Severe diarrhea drives a massive gastrointestinal loss of bicarbonate. That resulting metabolic acidosis forces the kidneys to excrete highly acidic urine, which ultimately precipitates these invisible stones.
So, because this precipitation relies entirely on an acidic environment, your absolute pharmacologic mandate is urine alkalinization. You achieve this strictly using potassium citrate. It acts as a profound buffer, aggressively raising the urinary pH to literally dissolve these invisible stones. And as a great secondary benefit, the citrate also binds urinary calcium, preventing simultaneous calcium stone formation. It's a real game changer.
Module 3, the genetic hexagon. Let's see how this builds into our third module, shifting our focus towards severe pediatric urologic presentations and hereditary transporter defects.
Take a look at the diagnostic microscopic signature for cystine stones, perfect hexagonal crystals. This pathology is driven strictly by an autosomal recessive defect in the proximal convoluted tubule transporter responsible for CoLA amino acids, that's cysteine, ornithine, lysine, and arginine. Because cysteine is so poorly soluble, it precipitates to form recurrent, massive staghorn calculi. Crucially, these predominantly present in young children, and they are only weakly radio-opaque.
Let's cleanly delineate the clinical variance between the two pathologies that actually form massive staghorn calculi. If you have an adult patient with recurrent UTIs and a highly alkaline urinalysis above 8.0, that calculus is strictly a struvite stone. Conversely, what if you have a young child presenting with a massive staghorn calculus and highly acidic urine? Well, that points directly and strictly to a cystine stone.
The master case, test in the nuance.
We've established the baseline mechanisms. Now we introduce the blueprint for the final master case simulation. This is going to force you to synthesize systemic GI crosstalk with an acute, radiographically masked urologic emergency.
Here's the patient profile blueprint. We have a 45-year-old male with a known history of severe Crohn's disease and profound chronic diarrhea. He presents with excruciating colicky left flank pain radiating directly to the groin. Now pay very close attention to the diagnostic trap embedded here. His standard KUB abdominal X-ray is completely normal. It demonstrates 0 visible stones. This is designed to aggressively tempt the clinician to incorrectly rule out nephrolithiasis or erroneously assume a musculoskeletal pathology.
Let's evaluate the exact 5-option matrix you'll need to navigate under real exam conditions. Option A, advise strict dietary calcium restriction. Option B, initiate oral allopurinol. Option C, administer a thiazide diuretic. Option D, prescribe a prolonged course of targeted antibiotics. Option E, initiate potassium citrate therapy. You must meticulously rule out the distractors to isolate the correct definitive pharmacologic therapy.
All right, let's walk through the flawless integration required to tear this apart. Option A, calcium restriction, is our classic dietary trap and would violently worsen oxalate stones. Option C, thiazides, prevents calcium stones, sure, but our patient's completely normal KUB proves this stone is radiolucent, meaning it is absolutely not calcium-based. Option D, antibiotics, targets a struvite infection, but those are radio-opaque and alkaline-driven. Option B, allopurinol, prevents uric acid synthesis in gout, but it doesn't alkalinize the urine to treat an acute presentation driven by GI bicarb loss. This leaves us with the exact mechanism. The patient's Crohn's-induced chronic diarrhea drives massive bicarb loss, resulting in a highly acidic urine environment. This forms invisible, radiolucent uric acid stones, which perfectly explains the severe pain despite the totally normal X-ray. Therefore, we forcefully bypass all distractors and strictly select option E, potassium citrate, to aggressively alkalinize the urine and dissolve that radiolucent stone.
To wrap up this explainer, I want to leave you with this provocative thought. What hidden systemic pathology is the next normal radiographic scan masking in your clinic? You must remain hypervigilant. Relying solely on basic imaging without executing deep physiological integration is exactly what will cause you to miss these invisible traps. Master the mechanisms, recognize the signatures, and you will never be fooled by a phantom stone. Thanks for joining me, and keep integrating.